Okay, class. So in this last unit, we'll get into the rehabilitation management of patients for heart failure. So it's interesting. When I started teaching cardiopulm and when I graduated PT school, exercise rehabilitation for heart failure was still sort of emerging as a routine practice, a routine aspect of clinical practice. Only as of 2014 was heart failure even approved as a diagnosis, an isolated diagnosis for cardiac rehab. And really over the past, several years, I was involved in this team here as an article reviewer for the cardiopulmonary section's heart failure clinical practice guidelines. So we're really, I think, for those, listening to this lecture, we're really at a time now that, was almost unthinkable, a few years ago, that we've got these, great position papers and great opportunities to really advocate and serve these patients through rehabilitation services. So, but again, the APTA cardiopulmonary section created a clinical practice guideline on heart failures. We're going to talk about some of these things. Again, we need to be aware of of this condition because we're going to see it often in practice, even in patients who aren't necessarily referred for limitations due to just heart failure. But if you're working in acute care, if you are working in geriatrics, and even some neurological populations, like this is going to be something that you're going to see often. It's again, it's an incredibly common and increasingly common condition. And with our advances in medical therapies, patients with even severe class 3 heart failure or above are living longer, right? So we're seeing even more complex heart failure. So again, it's the same kind of thing that we saw with cardiovascular disease, that often patients wouldn't survive MIs. And now those patients are able to survive MIs. We see more and more heart failure because of that, because people are able to live with these chronic conditions. And even with heart failure, which is the end sequelae, people are living longer with that as well. So you're going to see this. So this is the APTA cardiopulmonary section. Creating this resource was huge for our profession in providing evidence-based guidelines for PTs, and they produce these action statements, which we'll get into on the intervention. So, they recommended strongly that we must, not just should, we must educate, right, and facilitate components of disease management to reduce the risk of readmission. Again, we talked about how important it is for patients. If they're compensated, we want them to stay compensated. If someone has an exacerbation or a decomposition and gets readmitted or admitted to a hospital, that there's that partial recovery, that vicious cycle over and over and over again, right? We want to prevent that from happening. A lot of that can be done from, educating patients on nutrition, on maintaining activity, following their medication strategies, right? And it's a class A level 1 recommendation, education on chronic disease management. The next one would be prescription of aerobic exercise, right? Now this is primarily geared towards patients class 2, class 3, but this is even relevant for patients in class 1. And there's some things we can do even for patients who are a bit more severe. And there's some guidelines on what the APTA recommends for duration and frequency that aerobic exercise has to be a component of this, especially these stable class 2 and class 3 patients. The other is recommending interval training, right? There's great evidence now for patients with heart failure that, especially if they can't tolerate continuous aerobic exercise, to try interval training. And again, we can break that large unit of exercise into smaller chunks of higher intensity with breaks worked in, and we found that that may actually work better to stimulate some of those or facilitate some of those improvements in vascular function in these patients as well. So again, they strongly recommend high intensity interval training, class 1A recommendation. The other is lower body resistance training and upper body resistance training, so just strength training in general. Again, strength training, right? If we look at ADLs, most ADLs are strength-based, power-based activities. And while aerobic training, interval training, all that's great for some of those other mortality, morbidity, and vascular outcomes, when we look at independence and function, it's the name of the game is strength. So if we want to work on improving ADL performance, and maybe offsetting some of those changes in the muscle, strength training has to be a part of that conversation. So strong recommendations for resistance training for patients with heart failure. And then obviously there's probably some benefits of combining the two, right? So you get some unique benefits from aerobic training that you don't get from resistance training on the vasculature and other outcomes. And there's some obviously things that you get from strength training that you don't get from aerobic training, especially the ADL function. So they recommend as well considering a combination of the two. And then inspiratory muscle training. Now this is really for patients with weakness, right? But though they recommend it with or without, using this, intervention. We'll talk more about inspiratory muscle training in a bit, but for patients with dyspnea, with impaired exercise capacity, especially those who may not tolerate, conventional forms of exercise, this can be in an intervention to maybe get their respiratory muscles a little bit stronger, so they maybe tolerate more conventional, exercise, right? So maybe breaking things up and starting at this, very this mode of exercise. And for heart failure, we know that respiratory muscle metabolism reflex can really play a significant role in impaired exercise capacity. So if we can make those muscles a little bit more efficient, perhaps that reflex doesn't kick in, doesn't steal that blood flow, and it may allow them to exercise a little bit longer. And the data suggests that inspiratory muscle training can improve walking distance and exercise capacity in patients with heart failure. And there's also recommendations for including the combination of the two. And again, there's good evidence to suggest that this mode can be a nice primer for exercise. So giving patients a combination of inspiratory muscle training and a little bit of aerobic training to build up some strength in those patients, or build up exercise capacity gradually. And then now this is where things like, we've talked about this, I think, in other courses, but there's something for everybody, right? So we talk about those patients. Maybe someone's really not able to do too much exercise at all, right? They can't really even do an interval-based approach. They can't really do too much resistance training either. This is the role of neuromuscular electrical stimulation, right? We can do things, right? If people struggle with contracting their muscles, we can use different modalities to help strengthen them. So for patients who are at very low levels, right, who are just very limited, maybe at the beginning of an exercise program, NMES can be used to build up those muscles a little bit and maybe to bridge them to a traditional program. There's also some evidence on just preserving muscle mass too in these patient populations. So while this often gets a bad rap in conventional rehab circles, the use of NMES, well, there's patients who can't get a good contraction or can't really do traditional exercise. This is an opportunity here to use these devices to start them out, and then eventually transition them to a higher intensity. So, and the great thing about it, there really is very limited risk, if we place it on the legs, especially in terms of risks for an arrhythmia of some kind. You don't want to place it over the chest or the arms. But on the legs, the gluteals, the hamstrings, the gastrocs, those locomotor muscles, pretty safe for those patients. So a very strong recommendation for the use of NMES. And then there are some special exercise considerations for heart failure. You don't want to exercise right after eating or because of the shunting of blood to the stomach. They already have issues with perfusing muscles, so you want to make sure they have some time after eating. The other being after maybe using a vasodilator medication, just be careful with that because it could affect blood pressure responses. You might want to use peak exercise capacity as well, and you want to keep them below their symptoms. A great way to do this, if you do an exercise test, even if it's a submax test, you can get them right up until they start getting symptoms and then stop, and then prescribe exercise 10 beats below or 10, 15, 20 beats below those symptoms to keep them safe. And then, or you can use an RPE scale for them as well. Same kind of concept, like just work below that threshold so they stay safe. Be aware of signs of decompensation, fluid changes, any arrhythmia changes or cardiac ECG changes. Pulse narrowing, that means like their systolic and diastolic values get closer to each other. That's never a good sign, especially with other symptoms. And then your goal writing is just like any patient, right? Like you're going to try to structure things on function, independence, right? Like, getting patients to be able to tolerate ambulation, over commuted distances, in 4 weeks, just like you would do for any patient. Now, we'll go over some of the evidence for these interventions. So, we talked about what APT recommends, but here's the evidence, right? So that, aerobic training is considered the gold standard for heart failure. Again, we talked about, the evidence for this, or the recommendations for this. It's most often performed at moderate intensities, like it's recommended in the guidelines. Most studies utilize a recumbent stepper or a new step. That's where, it's a very well tolerated mode, or type. And or some sort of recumbent bike. That's done because it's a little bit easier to measure blood pressure and heart rate in those kind of semi-static, right? They're not moving as much as you would on the treadmill, so you can measure blood pressure a little bit easier and heart rate a little bit easier. And obviously associated with improvements in fitness, walk distance. The Minnesota Living with Heart Failure questionnaire is a patient outcome measure specific for heart failure. That allows us to track quality of life impacted by heart failure. So you may see this often, MLHFQ, and obviously all these other outcomes here too. As you may even see some peripheral and some central changes with aerobic training. Resistance training, we talked about this as well, utilizing modes to improve muscle mass, again, to really go after function, ADLs, and even attenuating the loss of muscle mass. Like there's a lot of great evidence to support that, heart failure is this, they're this catabolic state where they're cleaving and burning off muscle, or catalyzing muscle. There are multiple different pathways. If we can build up the amount of muscle mass or preserve it, again, the muscles talk to other structures in the body, and we think that maintaining muscle mass can be really important for survival for these patients as well. In addition to all the benefits on function and quality of life, we think physiologically there may be some benefit in preserving muscle mass. And it's crazy because this used to be something that was viewed as taboo. Like, why would you ever do resistance training because of the blood pressure responses to it? But we're finding if it's prescribed safely in a stable patient, it's fine. It's got to be monitored safely, prescribed appropriately. Interval training, and we talked about this. Now, interval training may not be tolerated by all patients. You need to be monitoring closely. But if someone can't tolerate continuous work, breaking it up into an interval might not be a bad option. Now, inspiratory muscle training, you're going to learn a lot about this during lab, especially in our pulmonary rehab unit. But basically what this does is patients will breathe against a set resistance using a threshold valve or a flow-based resistance. And we can load those breathing muscles. And the great thing about inspiratory muscle training, it's going to improve the strength of those muscles. We can prescribe protocols that improve endurance. That translates to improve exercise capacity and lower shortness of breath. And you typically see better benefits and improvements in patients with some baseline weakness or in patients who are more deconditioned. And you'll learn how to assess these muscles in lab, and we'll cover this in the pulmonary unit because we use this a lot in pulmonary rehab. But it's, the great thing is patients can do this sitting down. They can do it anywhere. So it can be very convenient for that patient who just isn't ready yet to start doing conventional exercise, even if it's cycling, like they just have an issue getting kind of going. This can be a great way to start by reducing dyspnea, giving them something they can experience success with, lowers their symptoms, and then you use that to bridge them to traditional programs. It's fantastic mode of exercise. Probably a little bit biased because it's kind of what my research is. And we also think it may help attenuate that respiratory muscle metabolite reflex that we talked about here. And there's even some evidence to suggest that in patients with heart failure, it may even have some effects on the airways too. So we think that there's definitely evidence to support respiratory muscle training and improving exercise capacity and tolerance to exercise and even ventilatory responses to exercise. But there's probably even more things that we're learning that may be involved here. And this is a paper that we had published back in 2017 on this respiratory muscle hypothesis in heart failure. This is the general protocol. And again, we'll spend more time talking about this, but we can prescribe endurance protocols, so starting at lower intensities for longer durations or higher intensities for shorter durations. And we'll learn a lot more about this later on. And then there's evidence as well for using CPAP. So CPAP is typically used to treat obstructive sleep apnea or BiPAP. We'll learn more about this and what this does. But basically what these masks do, this non-invasive ventilation, positive pressure ventilation, provide really a pressure jet of air to keep the airways open, provide a little bit of oxygenation as well. We also find that it improves cardiac function. Prescribing this in patients with heart failure has actually been shown, even if it's done the night before, but also done maybe 30 minutes before exercise, and even during exercise, can improve exercise capacity in patients with heart failure. So this has been looked at, and what we're seeing here is that if we provide a little bit of unloading by using those CPAP devices, that positive pressure ventilation to help expand the lungs, when we find it also helps allow the heart to pump a little bit more efficiently because of the changes in the thoracic pressure and thoracic volume. So here's a classic study demonstrating those exact findings. So as we can see here, with the use of that pressure unloading by using that device, the positive pressure ventilation, we can actually see during the unloading period, the stroke volume gets better. These patients with heart failure, compared to what they are at baseline. Now, not a huge effect, or beneficial effect in patients who are healthy, but in patients with heart failure, this has been looked at something that maybe we can utilize as maybe a way to prep them prior to exercise, or even do it during exercise, unload those breathing muscles to allow them to tolerate exercise a little bit better. It's just the same graph, the same population, but looking at leg blood flow, that in these patients of heart failure, again, stroke volume gets better, and so does the perfusion to their legs, because we're unloading the breathing muscles. They don't have to work as hard. So we are able to, perfuse our legs a little bit better, and they're able to exercise a little bit more comfort, a little bit higher intensity, a little bit more efficiently. Now, again, we talked about neuromuscular electrical stimulation. Again, there is something for everyone. In someone who is unable to exercise on their own, this can be a tool, right? There's something for everyone, and doing something is exceedingly better than doing nothing. And as we know, maintaining muscle mass is critical, right? The muscles have many more biological functions than just contracting and producing movement. So we can, in patients with heart failure who struggle maintaining muscle mass and lose muscle mass often sometimes it's disuse, but sometimes there are these catabolic processes, the ubiquitin pathway, different inflammatory pathways that cause catabolism of muscle. So if we can preserve muscle in any way, is great. And sometimes patients can't do strength training. They can't do even calisthenics. So NMES can be an opportunity to preserve those muscles in patients who are unable to do traditional exercise. And again, probably not if someone can do active contraction, if someone can perform exercise, probably not super beneficial. But this is really for those patients who are very inactive, who can't even move volitionally, just like we would in any other setting. And again, we haven't seen any adverse reactions in the research so far, especially if we place them on the legs. That's where most of the evidence is for, and that's why you would want to do it: quadriceps, soleus, gluteals. So just something to consider in patients who, again, aren't able to do anything. There's something that we can do to get them moving at a very basic, low level. So that was the exercise approaches for heart failure. Again, heart failure is a clinical population that we're seeing more and more often as we are having an older population. That bottleneck is now inverted. And even if you don't work in cardiopulmonary rehab or in acute care, you're going to see this often right? Even as an outpatient in PT, just because of how common it is in geriatric populations and how often PTs work with geriatric populations. And it's really the end sequelae of so many, lifestyle related diseases like hypertension, obesity, diabetes that you just need to be prepared to manage this or to be aware of it. So that was heart failure, and we'll end there. Thank you.